Thursday, April 1st, 2021. Will the clerk please call the roll?
Senator Valverde.
Here.
Senator Lawson.
Here.
Senator Bell.
Here.
Senator Calkin.
Here.
Senator DeMario.
Here.
Senator Golden.
Here.
And Senator Paolino, no. Chairwoman, we have 6 present. There is a quorum.
Thank you. All right, we have a number of bills before us tonight, and I believe 47 people signed up to testify. So we're going to go ahead and bring all of the bills and have the sponsors introduce all of their bills first before we go to public testimony. So the first bill we have before us is S62 by Senator Golden, an act relating to businesses and professions, confidentiality of healthcare communications and information act. Senator Golden, go ahead.
Thank you. So for those of you who have been on Health Committee before, this bill will be familiar to you. Essentially, what happens now is when we have health insurance with a policyholder that represents the policyholder holds the policy for the entire family, so that can include children up to 26 years of age on their parents' plan. It also means that the spouse or partner in that family is covered on the same policyholder. And when we see medical care, an explanation of those benefits is sent to the policyholder, and the policyholder is not necessarily the patient. For many people, this can become problematic because it can create a sense of fear or concern that they should not seek medical care because the policyholder will find out about their needed care. This is particularly true for those who are experiencing domestic violence situations or have left an abuser but maintain the same policy, maintain health insurance through that person's policy for some time afterwards. Concerns particularly about mental health. And then adolescents who are old enough to consent to their own medical care but are still on their parents' plan may choose to forego medical care instead of risking that there would be an explanation benefits sent to the policyholder. So this bill essentially creates a mechanism for people who are seeking care to be able to get that explanation of benefits not sent to the policyholder to maintain their privacy of their health visit.
All right, thank you, Senator Golden. Are there any questions? Senator Bell?
Thank you so much, Madam Chairwoman, and Senator Golden for introducing this legislation. I think this is a great piece of legislation. My question is very small and technical. OHIC suggested in their written testimony that they be excluded from having regulatory authority. And, you know, as you'll know, I rarely disagree, or I rarely agree with OHIC, but in this case, I think they might be correct. And it might make more sense to have regulatory authority all within the Department of Health. So we just have one body implementing regulations and we don't wind up with conflicting regulations. Is there a reason to have the two different entities having the authority to implement regulations? Or would you be fine with consolidating regulatory authority within the Department of Health?
This has been thank you for your question. This has been an ongoing conversation. Prior to COVID, Senator Miller and I were meeting with OHIC, the AG's office, the Department of Health, our health insurers, healthcare providers, and advocates to try and develop a system that would work. OHIC has now provided that information that they don't want to be part of that regulatory oversight. So we really need to go back to having a conversation about whether or not that Department of Health has the capacity to do that solely.
Okay, that's fair. They certainly need more staff assistance across the board.
Right. Any other questions? All right. I believe our next bill is by Senator Oyer. She might be joining us later, so we'll skip that for now, as well as Senator De Palma has not joined us yet either. Let's see. So I guess we'll skip over to Senate Bill 379 by Senator Mack. Senator Mack, are you with us?
I am.
All right, so go ahead and introduce your bill.
Okay, awesome. This is a Medicare, this is an audit of MCOs in our state, and our MCOs are up for a renegotiation of contracts in 2022. So this is a perfect time to make sure that our MCO, our managed care organizations, are providing are able to be appropriate middlemen between health insurers and or health providers and patients in the state. As of right now, there are 25% of Rhode Islanders who are on state Medicaid, and the state spends about 20% of its budget on our managed care organizations, which is about $1.7 billion a year. So this is a pretty significant chunk of our budget. This audit would allow us to determine where in the process we may be overspending on insurers and underpaying for medical care. And let's keep in mind that MCOs are not providers. They are middlemen to actually receiving care. We currently also do not have a sense of how much we are saving with private MCOs. In Connecticut, when they did an audit of their MCOs in 2009, they found that they were overpaying by $50 million per year. And this audit is coming at a great time because our contracts with our MCOs are up in 2022, and it's the perfect time to figure out where we stand. Thanks, and I look forward to any questions.
Thank you, Senator Mack. Are there any questions from the committee? Senator Calkin?
Thank you, Madam Chair. This is more of a comment. I wanted to thank Senator Mack for bringing this bill forward. Learning about what happened in Connecticut and how much money was wasted, I think it's about time that we do this here in Rhode Island. We should know where that money is going to, and if it's being wasted in some ways, given the percentage of our budget. And yeah, I just want to thank you for bringing it forward, and hopefully it's something we can do before we make another contract. Thank you.
Yes, and just to follow up with that, I believe in 2015, the Insurance Auditor General found that we had overpaid our MCOs by $200 million. So there is significant amounts of money that we could be leaving on the table if we continue to partner with MCOs without knowing where they stand in the process and how much money we could be realistically saving.
Senator Bell?
So I want to echo Senator Calkin's comments. Thank you so much, Senator Mack, for introducing this legislation. I think it's a really great bill. It's a more expansive version of the legislation I've introduced that takes us all the way towards having the deprivatization process begin. And I think, as you're very right to point out, now is really a good time to have that conversation because we are in the process of reopening the bidding. I believe that the Medicaid office just opened and put out an RFI, which is sort of a precursor step to doing the RFP. So I'm wondering what you think, what kind of impact you think this has on our budgeting process? Because of course, you know, the budget that we set for fiscal year 2022 is going to involve, as we move into these privatized contracts on the current timeline. So I'm wondering if you think that there are some implications for how we structure the fiscal year 2022 budget and the conversations we need to have as part of that budget about whether we move forwards with privatized Medicaid.
Yeah, great question, Senator Bell. I think it definitely will require us to think about where we want, especially in light of the global pandemic that we are still in. We need to make sure that all Rhode Islanders have access to great quality care. Right now, it has been shown through the audits that our partnership with MCOs has, in some ways, limited the amount of quality healthcare that people are able to access. And so I think the more resources that we can have that are going specifically to medical care and not to middlemen or to third parties, it'll make sure that as we are recovering from this global pandemic, we have more and more Rhode Islanders who are taken care of and whose health is a priority of not just the state, but of our budget as well. Every dollar towards healthcare should be spent on quality outcomes and not middlemen.
Great. Thank you, Senator Mack. Are there any other questions? All right. It looks like we've been joined by Senator DePalma, so we'll go back to S-171, an act relating to health and safety, the Rhode Island Rare Disease Medication Accessibility, Affordability, and Reinsurance Act. All right, Senator DePalma.
Thank you, Madam Chair, members of the committee. If I can indulge the committee, I do have a 6-slide presentation to at least walk you through why we're here. Then we'll talk about how it happens. So I can figure this out, and it is. Okay. And hopefully it shows up. I assume you see it, Madam Chair?
Yep, we can see it.
Okay. So why are we here? We're talking about real people. We're talking about real lives. This is one little girl, 14 months old. The drug that she needs to save her life, $2.1 million for the dose or for the treatment. So we're talking about rare diseases here. We're talking about rare diseases with treatments that are potentially in insurance formularies, and we'll talk about that in a minute. And as it indicates there, I'll share this with the committee, or Madam Chair, if you want to share it, you can. There's a link to the bottom down below where it talks about this article. And the treatment is called Zolgensma, if I said that correctly, and it could be one of the most expensive drugs in the world. Since it's not covered, what are they doing? GoFundMe. So they're up to $920,000 right now, and this drug could save this little girl's life and potentially stop the debilitating illness that she's experiencing right now. So let's talk about another part of why we're here, looking at numbers. And it's about, we're talking about cell and gene therapies and how many are expected to come about on an annual basis. There's not many, but the real focus here that I want to call your attention to is the treatment frequency. So you see it's relatively low. We're talking about 0.002%. And if you look at the estimated cost per treatment, we're talking some significant amount. A little bit less than the one we just saw a minute ago. But if we look at, let's just pick 2022, since that's what the bill is looking to address, it's just shy of $1.6 million. $1.6 million for a therapy. And if we go to the second table on the page, based on projections, using Rhode Island's population, based on what MIT has put forward for population data, and I can send you that as well, you'll see, and using the same treatment frequency up above, so take the treatment frequency, in the case of 22 of 0.002%, multiply by the population, you get 22. Take 22 times the potential cost of 1.6 million, and you get the about $34 million for the cost of that. The last two pieces that I'll go through quickly, Madam Chair and the committee, are projected costs based on the aforementioned populations. There again, looking at the same number of cell and gene therapies in that first row, the estimated cost per treatment, the Rhode Island population, and excludes Medicare. Medicare is not a part of this. You look at the estimated covered patients per year, that's what it's being looked at, based on that same percentage number of 0.002 for 0.002% for 2022. It's about 14 folks, annual cost about $23 million. What does that equate to an annual cost per person in 22? About $33. The average cost, the cost per month, excluding administrative fees, is about $2.07. Disregard the $2.70 right now. Ultimately, over a period of 4 years, it gets out to about $16.80 per year. And in some quiescent state, it will monotonically increase. I'm not saying it would ever go down, but we're looking at about a $200 cost per insured life. that we're talking about. So let's look down below. You'll see the numbers a little different. You're going to say, how can it be $2.80 when you just told me it's $2.70 up above? So the real cost is about $2.80 per month. And because what we've included in here is some admin and overhead costs for HHS, et cetera, to monitor the program. I think that's a little high, but rather be conservative on the costs than overly optimistic and find out it all can't be there. So you'll see what the fund grows to over time and what the cost becomes over time on a per member per month perspective. Just shy of $17 per member per month, as it shows in that column there. So, Madam Chair and members of the committee, the last page I want to show you, if it's there, and it's not there because it's right here, and let me just make this full screen. We already have a program. We already have a program in Rhode Island, and some members of the committee will remember. This may not be showing full screen there, but I apologize. I don't know any other way to make it full screen, and I don't want to jerk around and do something else. We have the vaccine assessment program that today, that's about $17.80, so $18 per month per child enrollee, and about $3 per month per adult contribution enrollee. So the $17 per month per child is similar to what we just saw on the previous page. So I'm going to stop sharing, Madam Chair, and we can talk about some questions. But what we're looking at here is a program that if the drug or the gene therapy is in the formulary of the insurance for which a life is covered, that particular group pays for it today. So it's either direct pay, it's small groups, large groups, and that cost gets spread over just the group that you're in. So if Senator Lawson, I'm going to pick on Senator Lawson for a second since she's looking at me. She smiled a minute ago, so I'll pick on her for a minute. If Senator Lawson, God forbid, needed one of these gene therapy drugs, and whatever insurance plan she was in, only the folks within the group that she's in, and that drug is in that formulary, will pay for that over time because it's part of the insurance and it gets spread out over everybody in that group. If you're in a self-insured group, like the state, some municipalities, and some private companies, unlike the state, similar to the state, where they're self-insured, excuse me, they may not have this gene therapy a part of their drug formulary. So in that regard, they're going to be like that little girl who, and there might be a child of somebody in there, that little girl, without that gene therapy, she won't have very long before she'll expire, basically. So what this seeks to do, what we did several years ago with the vaccine program, because prior to several years ago, the vaccine program did not include self-insured. I believe I might stand corrected, but I believe what we did several years ago, there may be some folks coming after me that will certainly have better insight on that. But what we did several years ago was included the self-insured as well. What this bill seeks to do, instead of limiting it to just pick on Senator Austin again, and the group with whom she's associated with, it would set up a restricted receipt account, a fund that would be maintained at the state level. And unlike the vaccine program, where the money's paid out, this is paid out after the fact. So I'm going to pick on Senator Lawson one more time. 3 times will be the charm. She gets a gene therapy. She's cured. Her insurance company applies to the state to get reimbursed for that particular coverage. And the state, through the program, will determine whether it's appropriate to be approved or not. That's the operation of it. There's many more details in the bill. If we don't believe the reason why it's important, the rest of the details in the bill are unimportant, just say. But that's what this seeks to do. I'm going to tell you up front, it does not exist anywhere across the country. It does not exist. And you won't find, if you do, I'll stand corrected there. Please let me know. We could be the first, maybe the second, but because someone might do it ahead of us, I'm not certain if it's been introduced in any states, but it seeks to do. If you focus on the why, if you believe why this is important, then we can have a conversation. If you don't, forget about the who, what, when, where, and how. It don't make a difference. Using some slang. It's about why we're doing this, and what this seeks to do is to spread the cost out across all lives. And at the end of the day, what does it mean on an annual basis? We're talking about a similar cost to what it does for prescription drugs, vaccinations for children at the adult level of about $200+. I forgot the exact number, but $200+ annually. So, Madam Chair, with that, I hope I didn't talk too fast, and I'll turn it back to you. Oh, by the way, I do want to one other piece. You'll see we received a letter from Director Savage, from Director of Taxation, who brings up some very good points, not necessarily with regards to the merit of the bill or not. She brought up some points with regards to, since it's related to taxing and where things go, that's better left with Division of Taxation than EOHHS is where it is. So, thank you, Madam Chair, and I won't be calling back again. So, thank you.
Any questions for Senator
Mr. Chairman.
Senator DePalma? I think Senator Lawson has a question.
I'm not going to pick on you.
Chairman. Thank you. My question, Senator DePalma, was when I have a newborn screening bill, and spinal muscle atrophy was the reason I went down that path. So one of the things that I found out that besides the great fact that there's a drug that will cure and save individuals' lives, the drug cost was very expensive, but it was still cheaper than treating the child if they did not receive the drug. So what I was wondering is, did you come across that in your research in any other instances that that these drugs, even though they're so costly in regards to the healthcare system, are more cost effective to provide them to patients and save lives or increase?
Senator, you are spot on. Unfortunately, I learned in my 13 years, we as a state don't care about long-term costs. Unfortunately, we can't see beyond the 1 year. We cannot look beyond the 1 year, but you hit the nail right on the head with regards to, by doing this, I'll just say, unfortunately, this little girl, from what I read, I believe it is SPA that she has, or SMA, spinal muscular atrophy or whatever, SMA. I'll just say it doesn't make it beyond some period of time. But other things would cause somebody that could do that. One other piece that I've been watching a while, and many folks here may have seen in the past, 60 Minutes had a segment on twice now, and it was phenomenal, about sickle cell anemia. And via the use of I'm going to get this wrong, I'm an engineer, I'm not a doctor, I value doctors, using the HIV or AIDS receptor. It's injected that with the cell into someone's body, and this young woman, probably in her late teens, who's an avid runner, who was completely immobile because of sickle cell anemia, I'll make it up a little bit to make the point, was back being active again because of that treatment. I suspect that treatment was extremely expensive, but the long-term costs and the other things that she would have needed had she not gotten that, I'm sure would have far outweighed the one-time cost of the initial treatment. So, good point to bring up that we need to factor that in.
Senator Bell also has a question for you.
Thank you so much, Mr. Chairman. And so, I think that there's a lot of merit in this bill. I really like the concept of having the state be the entity that takes on some of the risk hedging. And I think, as I think you know, I think the state should really handle all the risk pooling within healthcare. So I think that it's really important that we have a mechanism to ensure coverage and treatment of rare diseases, and I think this is a really smart model and a good way forwards. My question is about the innovative and very helpful technique you used by bringing up some slides with some numbers and data charts, and I found that very, very helpful. I think that was a great idea. I had always interpreted our new rules that we passed at, I guess it's Rule 10.17, as banning those kinds of visual aids in committee. But reading it again, I see that maybe it could be interpreted as only banning those for non-senators. And just for my future edification, because you're our rules chairman, I'm sure you understand all these details greatly. We are able to present visual aids as committee sponsors in committee, and we can use the same technique you used in the future.
I believe that's correct, Senator.
Okay.
I think it's the case where, because here's what would have happened if we were in committee. Well, we're in committee. So if we were in committee, in the finance committee, and you were going to hear about plate reissuance, I would have handed you a 11x17 spreadsheet of all the numbers about plate reissuance. So when we have that hearing, I'll make certain you're invited so you can see it in person, but I would have handed those out so I can walk through and talk to why this is important. I've even had other charts that I use to be able to brief the bill. No, it's no different than, I'll say, the various fiscal office providing presentations in the past, or the governor's office, the budget office presenting that. So,
thank you so much.
The answer is yes. If I am wrong, I stand corrected there.
No, I want to know so that we can use the same tactics. I think it's very helpful and really useful. And I had avoided that in the past, but now I'll be able to try and be clear by being able to use visual aids. So thank you so much for that.
I think the visual aid rule, well, Senator DePalma is chair of rules, so I think it's pretty clear it's to be used in committee and not on the floor, correct?
Right.
Okay. If there are no other questions for Senator DePalma, Senator Coyne has a question.
Thank you, Mr. Chair. Actually, I have a couple. I think they're really quick, though. So I appreciate you bringing this bill forward. I think it's got some really good reasoning behind it. My question is the price of those drugs, 1.5 million or whatever. Is there going to be anything done by the committee or whatever to see, like, if those drugs have been funded by us taxpayers, right? Because we know that, we pay our taxes and some of that money is used to develop new drugs. And sometimes these pharma companies still charge outrageous amounts for drugs, even though they've been funded. So do you know if there's anything in the process that's going to look at whether or not the funding for these drugs has come from taxpayers?
I can't say, Senator, because I don't know we'll make the assumption that, just for your argument anyway, that they're all U.S. drugs, right? There could be some that aren't U.S. drugs, right? I'm not going to presume to say we, U.S., have the keys to the kingdom on these rare drugs, given that they're N number per year coming out. So have not looked at that. But with regards to this committee has heard other bills, in fact, several weeks ago, that have been put forth. In fact, I know I have two of them. One associated with the drug importation piece, which is different. The other one about reference rates. Well, these are the ones that have come out, and they just come out yesterday, so to speak. And that's the case, though. If I could, did I answer your question, Senator?
Yeah, thank you for that. I think I just bring it up because it is something that seems very awful for the pharma companies to be charging $1.5 million for a drug. So, I appreciate what you're trying to do with the bill. The other part has to do with, so you intend to set up a restricted account for this money, and the money that funds that is coming from the insurance companies, right? Um, Maybe you can explain that a little bit more, because I was trying to figure out, like, your charts were very helpful, but does the money, like, say it's the $2.80 a month from all the ratepayers, does the insurance company have to collect that in a separate account that then goes to fund the restricted account?
The short answer is yes. Basically, that's the case. It would be, so it's either where there are insurance companies. And for many places, the insurance companies are just the administrator of the plans in the case of those that are self-insured. But that's the case is the money comes in. There might be folks coming after me that well, there certainly will be folks coming after me who know more about this more than I do, categorically. There always is more. Everybody knows more than I do about just about anything. But they will come to talk about that. But the money would be collected. By the way, the $2.80 really the first year. It grows over time till we get to some quiescent state, and then it'll monotonically increase. I don't think it ever goes down. I like to think it does, but healthcare costs have never gone down. Not that they can't go down, but even whatever plan we use, costs continue to go up over time. So they'll monotonically increase, but they would be deposited into the fund.
Thanks. And one final question, if you may. So there's a 15-person council that gets set up to manage this. I'm sorry if I missed it in your chart, but is there a cost associated with the committee, or just in the
So I didn't talk to the specifics about the council piece, but there's administrative costs for our state agency that has to administer and handle some of the applications and some other things that's setting this up. It's a very conservative number we put there, meaning it will currently cover the cost and then some. I'm a firm believer in under-promising and overachieving and give some money back rather than saying it's $10 when we come back and it's 20. Well, why didn't you tell me it's 20? Well, I wanted to do it with less. Tell me up front. Now I gotta go find $10 more. So that's a part of it. If I could go back, unless you had another question, Senator?
No, that's it. Thank you very much.
Going back to, Mr. Chairman, going back to address Senator Bell's comment. Yeah, the restriction in our rules on 1017, I thought was the case. It's about display of posters, signs, and banners being prohibited in the gallery or hearing rooms. So, I guess if you construe this to be a sign, a banner, or a poster, then what I had is I can't do again in the future. Or you have to erase it from the record. Just kidding.
So I would like to leave the rules debate to the Rules Committee.
Very good.
And go on with the Health and Human Services debate. Before we do, I would like to thank Senator Valverde for starting our hearing today. As many of you might know, there was a concurrent hearing in Judiciary where one of my little bills about marijuana was being presented with a joint finance committee, and I was asked to help present on that bill. And both in that committee and here, the committee is, the rooms are designed very large windows with window open and me more than 10 feet away from anybody else. For me, if I choose not to use my mask, some people ask, does the chair have a problem with masks? I absolutely do not. And I wear my mask all the time. But the way this room is set up with a 22-foot ceiling and only 5 people in the room, more than 10 feet away from me with a window open, just in case anybody was wondering, like they were up in Judd, similar setup in a similar scale of room with as few people in it. So just to clear that issue up. I believe the only other person that might present on their legislation today, we have Senator Gallo's bill. I believe she's not able to present on it. This is a bill that was introduced last year, developed by a legislator in Ohio that would adopt an interstate compact to award prizes for curing diseases. Senator Mack presented. Senator Coyne, who is chairing Health and Human Services, has Senate Bill 650 assisted living residences would require the Department of Health create an informal dispute resolution process for addressing violations in assisted living residences. She also has Senate Bill 651. Breast cancer would allow individuals updating how breast cancer screening results can be transmitted to include mail, electronically, or otherwise. Senator Archibald's resolution requesting that Rhode Island Department of Health increase public awareness of activities that expose people to ticks, better educate the public about the symptoms of Lyme disease and the importance of early detection, and update their findings, data, and physician protocols with regards to early detection and treatment of Lyme disease. Senator Goodman's bill, which simply removes a sunset provision on the state medical examiner's office on the requirement that the Department of Health engage in multidisciplinary team reviews of drug-related overdose deaths. Also, I would like to briefly present on Senate Bill 495 that I have introduced, the Rhode Island Health Information Exchange Act of 2008, would switch the patient participation in Rhode Island Health Information Exchange from opt-in to opt-out. The opt-in, opt-out model, I think, was best demonstrated in its effectiveness in a bill that was passed when I was in health. I believe it was at least 10 years ago, from Senator Levesque. And what it did is we changed opt-in to opt-out on AIDS testing for expecting mothers and newborn infants. And it was modeled after incredible success in Connecticut when they did the same thing, and how many lives and how many hundreds of thousands, if not millions of dollars it saved in medical costs based on identifying AIDS in both mothers and newborn babies as they changed it from opt-in to opt-out. And I believe that it went from, I think it was around the 50% range of testing to 99% as the context of the same tracking went on a couple of years before we passed that legislation in Connecticut. And I think the pandemic has demonstrated how useful and important that kind of data can be, and that kind of opting out rather than opting in structure can be to alleviate not only lost lives, but averting extraordinary medical costs also. Is there any question from the committee on that legislation before we go on to the phone calls? If not, we'll go on to the phone calls. The first, if we have it right, Justin, do we have Dr. Qureshi? Yes. Dr. Qureshi? Dr. Qureshi, I believe you're on the line.
Yes, I am.
Go right ahead and make it clear to us before you testify if you represent an organization or are you speaking for yourself, and which bill or bills you are testifying on.
Sure, absolutely. So my name is Abrar Qureshi. I'm a professor and chair of Department of Dermatology at Brown, and I'm really speaking on my own behalf, although I chair the Department of Dermatology at Brown. We do a fair amount of clinical care and, of course, research in the state. And I'm talking about this is the opt-out bill for the healthcare exchange that we have in Rhode Island. And really just want to make just one major point today. I wish we could do this in person, of course. The point is that healthcare exchange, we're very fortunate to have a healthcare exchange in Rhode Island run by the Rhode Island Quality Institute. As you know, our healthcare exchange, the one we access at least as physicians when we're providing care to the patients, it's called Current Care. And the recommendation is to allow this to be an opt-out type of healthcare exchange, meaning that everybody who'd be getting care in the state of Rhode Island would actually be included or be registered, and that data would be collected on this healthcare exchange, and they would have to actually opt out versus what we have currently, which is an opt-in version. Now, why as a physician, as a healthcare provider, as a dermatologist, as a researcher, am I for this? Well, simply, when providing care to patients in the state, the patient can be seen in a particular emergency room, a particular hospital, maybe a clinic with a specialist or another primary care doctor. They may get labs drawn at a particular laboratory, or and then a few weeks later go to a different laboratory. They may go to two different pharmacies to have their medications filled. They may actually never get their medications filled, even though prescription's written. All that data can be collected at a point of care, so a physician providing care to a patient will have access to all that very important information. And why is that important? Because it allows us to provide the best care possible. So a patient presenting to me, let's say in dermatology clinic, they may have a complicated skin cancer problem. They may have had a biopsy done at a different venue. And if they are in the healthcare exchange, I may not have to spend valuable time calling that facility, getting the lab results, the pathology results, etc. It would be actually readily accessible to me immediately. But it's not just for one type of medicine or one type of physician or one type of patient. This really applies across the board to any kind of healthcare problem we're talking about. Could be related to the opioid crisis we're facing, maybe related to problems with duplicate medications, medication errors, excess laboratories results being sort of used. So, for example, a patient who may have had a complete blood count a few weeks ago, if a physician has access to that in the healthcare exchange, they may not need to draw blood again for want of just ease of access to that initial blood test. So for all those reasons, I personally, am very much in favor of an opt-out type of program where patients receiving care would have the data collected and that be accessible to them, of course, as well as their healthcare providers at the point of care.
Any questions for Dr. Qureshi? Thank you for calling in.
Thanks so much.
Before we continue with calls, I don't believe we went through an explanation of Senator Oyer's Bill 169. We might be receiving some phone calls on that, which would create licensing requirement for laboratory technicians. Intent is to provide better protection for public health and to ensure that medical laboratory tests are performed with the highest degrees of professional competency. As we've had this bill in the past, and the testimony has been about contracting out and the quality of the testing on some of that work that is contracted out. And as somebody who's had family members who are licensed lab technicians, I understand the issue and appreciate the pursuit of the legislation. Next, I think we're going to connect with Adam Cable. Mr. Cable?
Yes, hello.
Before you testify, just let us know if you're testifying other than yourself, such as an organization, and which bill or bills you wish to speak on.
It's just testifying for myself, and I'm testifying about, I believe it's Bill 379.
Go right ahead.
Thanks for listening to my testimony. My name's Adam Cable. I'm a behavioral health provider in Rhode Island, and I'm testifying in support of deprivatizing Medicaid. I also formerly was a Medicaid recipient myself, which was a life-saving service for me to have. The reason I'm in support of this is because I've seen how privatizing the system has taken money out of our state and put it in the hands of a private company that pays its executives and its shareholders lots of money, and also pays millions and millions of dollars in lobbying to politicians on the state and federal level to keep the system in place. It's a really inefficient use of resources that could go towards paying providers more and giving better services for Medicaid recipients. Providers in Rhode Island have, particularly behavioral health providers, have stopped taking insurance because the rates are so low, meaning that there's a drastic dearth of providers in the state. Almost everybody I know who works in the field is full and has a waiting list, and often people's waiting lists are full. We really need to attract more providers to the field, make the reimbursement process easier, and I can tell you from experience that companies like United and Neighborhood, which contract with Optum for their behavioral health service provision, purposely make it complicated for providers to get reimbursement so that they can manage to not pay them. So I'm asking that you very much consider bringing Medicaid back under state control and stop providing excess profits to private companies like these. Thank you.
Any questions for Mr. Cable? Thank you for calling in.
Thanks.
Next, we'll try to connect with Al Charbonneau.
With Optum for their behavioral health.
Mr. Charbonneau?
How are you?
Good. Can you please turn down your feed so we don't get that delay?
So that they can manage to not pay them. So I'm asking that.
I'm doing that now. Thank you.
Good. Thank you. And before you testify, can you indicate which bills you'll be testifying on and whether you're representing yourself or any outside organization? I assume it's the Rhode Island Business Group on Health.
Yes, my pleasure. Excellent. I'm Al Charbonneau, Executive Director of the Rhode Island Business Group on Health. I'm speaking this evening in support of Senate 171 and Senate 495. I'm speaking on behalf of the Board of Directors of the Rhode Island Business Group on Health and its 90-member companies representing 80,000 employees here in Rhode Island. We are expressing our support for Senate 171 because we think it takes an important first step in addressing pharmaceutical costs. We hope that the Advisory Council will be responsible not only for helping to identify drugs and determine the assessment level of participants, but also for assuring the fully insured and self-insured participants that resources are being used effectively. A successful rollout of 171 could pave the way for even more collaborative and innovative solutions for the extraordinary pharmaceutical costs incurred by all Rhode Islanders. Can I move on to 495?
Yes, and if you have written testimony you've already submitted, try to paraphrase that instead of reading it, because we will read the sentence.
Yes, I believe that I did paraphrase it. I'm speaking also in support of 495 because the medical literature supports the use of a robust health exchange to improve quality and lower the cost of care. The COVID pandemic has highlighted another reason to make the exchange move from an opt-in to an opt-out, in that public health officials see extremely high value in the use of the HIE during a pandemic. So we support S495 because greater participation will not only help to raise quality and lower costs, but it will keep us better prepared for the next pandemic. Thank you, Mr. Chairman.
Thank you for calling in. Are there any questions for Mr. Charbonneau from the committee? Thank you. Next, we will try to connect, or we will hear from Ames Colt. Mr. Colt? Mr. Colt?
Yes.
Go right ahead. You're on with the committee. Just let us know if you're representing yourself or any organization, and which bill or bills you wish to testify on.
I'm representing myself. I wish to testify on Bill S379. We need to remove the private health insurance industry out of our state Medicaid. It creates a bottleneck of services. It makes services more expensive and harder to obtain. Healthcare is a human right and should not be commodified under any circumstance. Thank you.
Any questions for Mr. Colt? Thank you for calling in.
Thank you.
Next, we're going to try to connect with Anita Keston. Okay, we're now connecting with Brian Jordan. We will try Ms. Keston later. There was no answer. Mr. Jordan, before you testify, can you please indicate if you're speaking for yourself or an organization and which bill or bills you are testifying on?
Sure, Mr. Chairman. Brian Jordan on behalf of the Rhode Island Assisted Living Association, testifying in support of Senate Bill 650.
Go right ahead.
All right. Thank you, Mr. Chairman. I want to thank, on behalf of the Assisted Living Association, I want to thank Chairwoman Coyne for sponsoring the bill, and certainly you, Mr. Chairman, for co-sponsoring it. Just quickly, Senate 650 amends the Assisted Living Residents Act by creating an informal dispute resolution process. This process is intended to provide basically for an exchange of information between the health department and licensed assisted living providers, which ultimately could lead to the modification or deletion or removal of a violation or even parts of a violation or enforcement remedy imposed by the department. This process allows for the efficient resolution of any disputes prior to resorting to the more formal process found in the Administrative Procedures Act process. Just by way of background quickly, the DOH did have an informal dispute resolution process for assisted living residences. They established it through the regulatory process probably over 7 years ago in a prior administration. One of our members in 2019 was informed that the process was no longer in place, and that's why we requested this legislation in order to provide a statutory framework to reestablish the process for assisted living providers and to make sure it's there in the law should the administration change or should the DOH director change, that type of thing. Currently, federal law requires state health departments to have an informal dispute resolution process in place for nursing homes, but not for assisted living residences. This bill provides assisted living residences and the DOH an opportunity to informally discuss and resolve disputes that arise from the department's compliance surveys, just as they would for a nursing home. So certainly I think as more nursing home organizations are building or incorporating an assisted living facility into their operations or on their campus, this resolution process makes a lot of good sense for for their operation. So we respectfully urge passage of this bill. Thank you.
Any questions for Brian? Senator Bell has a question.
Yes.
Thank you so much, Mr. Chairman, and thank you for your testimony. I have to say, I have serious concerns about this legislation. I think coronavirus was a real eye-opener into the importance of strong regulation of long-term care facilities. Full disclosure, my wife's grandfather passed away in an assisted living facility that had a cluster of COVID cases across New England. And so I'm I'm perhaps biased in this issue, but I'm very concerned about ensuring that we have a very robust system of health regulation in place for assisted living facilities, especially in light of the pandemic. And what this bill actually does, I think, severely undermines the regulatory authority of the Department of Health. And specifically with regards to timing and speed, it requires that any action be reviewed by someone who was not involved with the original action, and then it requires that there be a meeting in place before violations are imposed and things like that. So I am extremely concerned that it slows down the speed at which action can be taken. And I'm also concerned that it becomes mandatory, that it's not something that the Department of Health can impose, but it's mandatory to impose this process, which really seems to tilt the overall playing field against stronger regulation of assisted living facilities. And I think it's really difficult for us to look at this past experience of the pandemic and think that we need to weaken the regulatory authority over long-term care facilities in general. So my question is whether you would be okay with having this legislation be changed to create an optional process rather than a mandatory process that could be used when the Department of Health or to slow down the implementation or to mess with an enforcement action when it really needs to be put in place right away. I'm concerned that this is just going to tie up all assisted living enforcement actions with additional paperwork. So I'm wondering if you would be willing to accept it as an optional process if the Department of Health finds it helpful, rather than a mandatory process that can be used to obstruct reasonable regulation when the Department of Health does not wish it to be used as such.
Well, thank you, Senator. That's certainly something I could discuss with our client. The process is, I guess you could say, it's informally informal now, if you will. It is fairly optional, but it basically mimics the process that's in place with nursing homes right now. And as we find more assisted living residences being built on the campuses of nursing homes, I think it just makes sense to have an identical process in place. My parents are both in nursing homes. I have really not been able to see them in the past year, so I'm extremely sensitive to stringent regulation being in place at assisted living facilities and at nursing homes. But to get back to your question, it's certainly something I can bring back to my client.
Thank you so much. I think this legislation be much improved by making it non-mandatory.
Sure.
Any other questions? Thank you, Mr. Jordan.
Thank you, Mr. Chairman.
Next, I think we're going to connect with Craig O'Connor. Mr. O'Connor?
Hello, Mr. Chairman.
Can you just please identify the entity that you might represent and the bill or bills that you wish to testify on?
Of course. My name is Craig O'Connor. I'm with Planned Parenthood of Southern New England, and I'm testifying today in strong support of Senate Bill 62. Senate Bill 62, submitted by Senator Golden, is the Confidentiality of Healthcare Communications and Information Act. She did a great job of introducing the bill and what it would do. I've submitted written testimony, so I'm not going to repeat what is in my written testimony. I just wanted to make 2 quick points. First, I wanted to say thank you to the many members of this committee who are co-sponsors of the bill, including Senator Valverde, Senator DeMario, and yourself, Chairman Miller. The second point is often in the process of making policy, policymakers do disregard voices of young people. At Planned Parenthood, we work with a lot of young folks, both as activists and patients. I would like to encourage the committee to look at the submitted written testimony for the voices of young folks. A number of college students that we work with have submitted testimony. These include Maria Zhu, Ellie Lucia, Harley Jones, Peyton Johnson, Tatum Camacho, Emma Lynch, and Ilse Bryan. I'm not sure if any are speaking today, but they've all submitted written testimony about how important this issue is in passing this legislation is to young folks, especially as Senator Golden mentioned earlier. Young folks are staying on their parents' health insurance up to age 26 more commonly now because of the Affordable Care Act. I would also like to encourage the committee to go to Facebook and watch the Facebook Live event that the Rhode Island Health and Privacy Alliance held this afternoon. I'm sure someone else will also talk about the event, but that gives a very comprehensive set of statements around why this legislation is so important to protect the privacy and the well-being of so many patients throughout our healthcare system. And again, there was a younger person who was a student at Brown University who spoke about the import of this legislation for folks in her age group. Again, Planned Parenthood strongly supports this legislation. We thank the committee for considering it. We hope you pass it and recommend passage to the full Senate. I'd be happy to take questions.
Any questions for Craig? Thank you for calling in.
Thank you, Chairman.
Yep. Next, we're going to try to connect with Dr. Neil Sarkar. Dr. Sarkar, I believe you're on the line. Oh, Neil Heitman. I'm sorry.
Hi, Chairman. How are you? Can you hear me okay?
Yes, I can.
Excellent. Thank you, Chairman.
Just identify who you're representing and what bills you wish to discuss.
Perfect. Thank you, Chairman. Neil Heitman from the Rhode Island Department of Health, and I'm here today to speak on our bill, Bill 713, introduced on behalf of the department by Senator Goodwin. I want to thank her for her sponsorship of this bill and the original bill, which passed in 2018, that created the Overdose Fatality Review Team. In 2018, the General Assembly established this team and tasked them with conducting comprehensive systems reviews of overdose fatalities. The team's goal is to identify overdose risk factors, to improve local prevention planning, identify missed opportunities for prevention and intervention, and make recommendations to law, policies, programs to prevent future overdose deaths, and increase interagency communication and collaboration, trust, and buy-in around overdose prevention. The Overdose Fatality Review Team meets on a quarterly basis and includes stakeholders from the prescribing community, our first responders, treatment providers, members of the recovery community, addiction specialists, our medical examiner's office, and our prevention coalitions. After each meeting, a data brief of key findings is published and shared with stakeholders, including the Governor's Task Force on Overdose Prevention and Intervention and its working groups. And stakeholders then work to identify ways to incorporate the findings of their work. So over the past 2 years that this team's been stood up, some of the things that they've done have advised
strategically distributing naloxone to groups in geographic areas most at risk during risky times and risky seasons, targeting peer recovery specialists and community health workers to engage individuals most at risk and connect them to help or sustain treatment and recovery and connect them to basic needs, support and develop policies and regulations that improve safe and responsible prescribing, and tailor and adapt harm reduction messaging and media to decrease overdose risk among at-risk populations. So really the purpose of this bill is because of the focus of these reviews is on public health systems focused on prevention and intervention and not legal action against the decedent or witness. It's important to have the language retained in statute that the work product of this team not be made available for use in court proceedings. And the work product of this team is never intended to be used to make arrests or prosecute specific individuals, and the language included in current statute ensures that those goals will continue to be met. So we've provided the committee, along with a written testimony, a copy of our team's most recent annual report. And we'd be happy to provide the committee with any additional information it would like to continue this team to continue doing their important work. So thank you, and thank the committee, and happy to answer any questions.
Any questions for Neil Heitman from the DOH? Thank you for calling in.
Thank you, Chairman.
Yep. We're trying to connect with our next caller. I think we have him now. The other Neil, Dr. Neil Sarkar.
Yes, speaking.
Go right ahead. Just let us know which bill or bills you're testifying on and whether you represent an organization or speaking on behalf of yourself.
Sure. So thank you, Mr. Chairman and members of the committee. I'm going to be speaking in support of Bill number 495, and I am speaking in my capacity as President and CEO of the Rhode Island Quality Institute.
Go right ahead.
Great. So thank you, everyone, for the opportunity to speak with you this evening. The secure sharing of data between medical doctors and others on the patient's healthcare team is at the heart of delivering the highest quality of care. Current care ensures that the right medical information is available to the right person at the right time, in the right format, and in the right way. The information is made available in a confidential and secure manner to only those who are authorized as outlined in the Health Insurance Portability and Accountability Act of 1996, which we commonly refer to as HIPAA. Current care reduces medical errors, reduces clinician burnout, helps control healthcare costs, and improves public health services. Currently, the potential life-saving services of current care are only available to those who are asked, what we call opt-in. When Rhode Island pioneered current care, consumer protections on pre-existing conditions and other privacy laws simply did not exist. There are now explicit safeguards in place which provide patient choice and still ensure confidential and private availability of medical data. The opt-in enrollment policy prevents half of our state's population from benefiting having critical information, for example, allergies to medications at critical times of need. The passage of S495 will enable current care to provide life-saving information to doctors and their teams within secure clinical systems for Rhode Islanders, regardless of where care is sought in our state. This will reduce clinician burnout by saving time and searching for information from different facilities, making phone calls, or depending on patients or their families to rehash basic clinical information. A recent survey of more than 100 stakeholders across Rhode Island revealed that the consent model of current care is a significant barrier for providing the best care for patients in our state. A few years back, current care helped me. I was admitted to Rhode Island Hospital with an infection caused by a scratch from our recently adopted cat, Tiggy. After discharge, my regular physician, who works in a different healthcare system, was able to access information about my stay alongside other notable health events that occurred earlier that year. Current Care shows that all my medical data were available to all my doctors. Now, before the pandemic, I would have been speaking hypothetically about the merits of S495 during a public health emergency. I can now definitively speak to the challenges of having only half of Rhode Islanders represented in Current Care within the context of COVID-19. Compared to 42 other state-designated health exchanges in our nation, we were not able to leverage Current Care to fully support the public health needs related to diagnosis, testing, or vaccines. The passage of S495 would enable Rhode Island to be prepared for the next pandemic. S495 extends the value of Current Care to all Rhode Islanders and still retains their choice to participate. Current Care saves lives. It represents an essential step towards making Rhode Island the healthiest state in the nation, built on equitable access to core services like Current Care. Thank you for your time, and I'm happy to take any questions.
Any questions for Dr. Sarkar from the committee? Thank you for calling in.
Thank you so much.
Yep. I believe next we're going to try to connect with Dr. David Garlick. Dr. Garlick?
Yes.
Go right ahead. Just let us know whether you're testifying on behalf of yourself or another organization and which bill or bills you wish to speak on.
I'm testifying on behalf of myself, and I'm actually following the same bill, the 495 that was just discussed.
Go right ahead.
Okay, thank you. I'd like to take a few moments to explain why changing Current Care to opt-out is necessary, and I'm going to provide some background as if it's applicable to the discussion. I was board certified in internal medicine in 1993. I began work in an ambulatory setting. I needed organized data, so I created a simple database to compile and track medications, allergies, medical history, problems. This was not an electronic record, so data was not available, such as labs, imaging tests, consult reports. I was a physician advisor to the Rhode Island Quality Institute for over 10 years. In the early 2000s, we worked to identify the essential functionality of electronic records. That was the initial phase of transforming Rhode Island healthcare, helping doctors' offices become electronic, thereby creating efficiencies and having data more accessible at the point of care. I was also on the advisory committees that helped to create Current Care. In 2005, I was considered an early adopter with electronic records, and I ran a pilot project for the development of the patient-centered medical home, which has become the standard. The medical home creates workflows and efficiencies, team-based care to improve the patient experience, improve the health of the community, and reduce healthcare costs. I was appointed to the first Health Information Exchange, or Current Care Advisory Commission, by Governor Chafee in 2013. I served as the chair of the commission for my 3 terms. Despite all of the work that I've done, I still don't have access to all of the necessary data. Using an electronic record only provides data that's within your office or health system. External data, tests, hospital admissions, outside consultation reports, they all need to be sent to you and processed so they're incorporated into your record in order to have access to it. This is labor-intensive and unreliable. Current Care, the Health Information Exchange, is the key. However, the current opt-in requirement is restrictive. It limits the data that's available to healthcare providers. If a doctor logs into Current Care to find data and sees that it's not available because the patient did not opt in, that's problematic. If you do that several times without available data, you learn not to log in because it's a waste of time. It's not productive. We need the data. Current Care needs to be opt-out. That will provide data at the point of care. It will positively impact individual patient care and give providers the power they need for impactful population management, focus on specific diagnoses, zip codes, healthcare disparities. Changing to opt-out is essential. I appreciate the opportunity to have spoken today. I can answer any questions if there are any.
Any questions for Dr. Garlick? Senator Bell does have a question for you, Doctor.
Certainly.
Thank you so much. I actually have 2 questions. My first question is, Around the patient privacy issues, by making information opt out rather than opt in, what ability do we have to make sure that patient privacy is protected? And so the second question I have is around the issues with population health management. I think population health management can be a very successful model. However, we have had significant difficulties with population health management and alternative payment models in Rhode Island. And I'm wondering and I'm concerned that this legislation might actually encourage the use of alternative payment models. So what kind of assurances do you have that this legislation will not encourage the use of alternative payment models, which have been, kind of a mess in our implementations?
Well, the previous speaker might be more applicable in terms of the login protection of privacy as its current care and their protection of who gets to log in that would really speak to the patient privacy. In my experience, I would expect that the only people that are logging in to view data is going to be healthcare providers that have been vetted by the Rhode Island Quality Institute, that have authorization to log in. Every login is traceable and tracked, and patients, as far as I'm aware, should have the right and do have the ability to get a report of anybody that's logged in and look at any of their data. So there are protections built in, but again, the previous speaker would be able to speak more to that. In terms of population health and alternative payment models, I'm not actually involved with payment models. I don't run the payment systems and projects and the contracts in my office, so I'm really not in a position to speak to that.
Through the chair, if I may, part of the reason I asked about the questions about alternative payment models is in your testimony, you mentioned that these data are necessary for implementations of things that involve alternative payment models, such as the patient-centered medical home initiative, which is part of the broader move towards alternative payment models that has been part of some of the healthcare policy direction that the previous gubernatorial administration had emphasized. And so part of your testimony seemed to be that it's really important to gather these data for the use in alternative payment model issues, such as patient-centered medical homes. Am I misunderstanding what you were saying? Could you perhaps clarify what you were saying earlier about the gathering of data?
Yes, certainly.
For use and things like that. Was it about something different from payment models?
Yes, I'm not here testifying as an organization, I'm testifying as a doctor, and the way I'm looking at this is taking care of my patients. So if I have 1,500, 2,000 patients, I can take care of them one at a time as they come in the door. And I can also take a look at all of the data on all the diabetic patients or high blood pressure patients or people who have had strokes and make sure that when I review the records of all of the population that I'm trying to manage, that I have them on the right types of treatment, that they've been in for their visits, that have had their blood work that they need to monitor their care. I'm looking at it as a doctor, as a provider, trying to get my patients the care they need. When I can look at population data, I can look at my patients and try to target where I need to spend more effort for filling gaps in care. That's the type of way in which I would use the system. So I'm not looking at it from funding. I'm not looking at it as policy. I'm looking at try to get my patients the care they need. And with the opt-in methodology here, it's very restrictive. The data is just not available.
Thank you so much. That was a very helpful clarification. I had misunderstood what you initially, your initial testimony. So thank you so much for that.
Senator Bell.
I am still concerned.
Yep. I believe that Dr. Sarkar, who is from the Quality Institute, which manages the database, and our next caller that we're going to try to connect, Diana Franchito, who is also from the Rhode Island Quality Institute and manages the database, that they might be more appropriate to answer those questions because they're currently managing it on the opt-in structure, and they're not testifying on behalf of themselves, but on behalf of the organization which currently manages the database. So Senator Coyne, you might want to wait for the next caller unless there's something specific to
No,
the doctor.
I actually have a question for the doctor.
Go right ahead.
Thank you, Mr. Chair. So you just said that by having it as an opt-in, that you're not getting the data that you need. I'm trying to understand why this is. Is it because when you offer the patient the chance to opt in that they are refusing to have their information shared?
Yes. So there are a lot of doctors in the state, and to try to get the consent of all of your patients in the population of patients that you're caring for, it's a lot of work, and a lot of patients are very skeptical. When you review the consent process, it can be intimidating because of the wording that was required for the consent to have. And some patients just don't understand the implications. It's really a safety measure to provide them better care. So if the patients are not willing to sign up, and if it's difficult to get people to sign up, there's only so much time and effort in a very busy practice that you can expect doctors to spend when the yield is going to be less than optimal in getting patients to actually agree to consent.
Thank you for your answer. That is kind of my concern around these opt-out bills, is that what you're saying about giving the patient the option to then opt out, that they might be confused about what it means, and there may be patients who really don't want their information shared in this manner, that by having it be opt-out, that they might not be choosing the option that they would have preferred. But I thank you for your answers to the questions. Thank you.
Yes.
Any other questions for Dr. Garlick? Thank you for calling in.
Thank you.
Now, as I mentioned, the next caller is a second representative from the Rhode Island Quality Institute, Diana Franchetto. Diana?
Yes.
Go right ahead, and I think I properly identified you as another representative of the Rhode Island Quality Institute, which is currently managing this database.
Okay. Good afternoon, everyone. Thank you, Mr. Chairman and members of the committee. I'm Diana Franchetto, the chair of the Rhode Island Quality Institute Board, and I'm here to testify on behalf of Senate 495. As the chair of the Rhode Island Quality Institute for several years, some of you may also know me in the capacity of
Go right ahead.
Yes.
Yeah, it might help if you turn down the feed so you're not getting the delay.
How's that?
That's better.
Okay. Hello, thank you, Mr. Chairman and members of the committee, for the opportunity to make a few comments regarding Senate 495. My name is Diana Franchetto, and I serve as the chair of the board of the Rhode Island Quality Institute. And some of you may also know me in my capacity as president and CEO of Hope Health. Neil Starkar earlier reviewed the significant benefits of moving toward a more inclusive approach for all Rhode Islanders to easily be part of current care. I want to share with you that on behalf of my colleagues on the RIQI Board of Directors, we are unanimously in support of Senate 495. As noted in the letter of support which I sent earlier this week, the board of the Rhode Island Quality Institute not only includes large healthcare systems and hospitals and practices in Rhode Island, but also academic institutions, the entire payer community, the physician community, other important healthcare providers, and community representation. As the board of RIQI, we want to ensure that current care is there to support the Rhode Island healthcare ecosystem in a way where meaningful contributions are made every day so that all Rhode Islanders benefit from coordinated and high-quality care made possible by the state's health information exchange through Current Care. Thank you for consideration of this bill, which will enhance access, support public health, and reduce healthcare costs. I'm happy to answer any questions that you may have or more technical questions with Dr. Neil Sarkar.
So I just want to, on behalf of Senator Bell, kind of try to paraphrase what he asked. Did you hear him ask his questions to the previous caller?
No, I did not.
Oh, okay. So I'll let, he already had his hand up, so I'll let him go over that. But some of the questions are around the privacy and HIPAA issues and the alternative payment models and how they discourage or encourage the services under alternative payment models. And Senator Coyne also asked about the challenges of opt-in versus opt-out versus HIPAA and other issues and privacy issues. I don't want to paraphrase for them, but those are some of the questions that would probably be more appropriate for you or Dr. Sarkar rather than Dr. Korolik, who was speaking on behalf of himself.
Right. I think Dr. Sarkar is in the best position to answer the question.
Yep. So we'll make them available, not as calling in again so we can move ahead, but we'll make them available to any senators who want to contact him directly, either by email or arranging a call between them.
Sounds appropriate.
I think it might be Senator Coyne does want to ask you or clarify. So if you could hold on for that.
Thank you, Mr. Chair.
Yep.
I actually have questions regarding the data in the database. So
yeah, sure.
Thank you. So I guess my question is, could you maybe describe a little bit around, and I don't know if you can do this or not, but the security that's in place to prevent hacking of the database? And also, you mentioned that there are like education type of facilities or whatever that have access to this data. And can you maybe describe the security that goes in? Like, I'm assuming that for someone that's looking at it for educational purposes is not receiving information by patient. Can you kind of confirm that information?
Sure. So from a security, as you can imagine, when you are a health information exchange, it is a highly secure environment. It is a highly secure environment.
So do you not have the information regarding security processes or anything like that? Or maybe is there someone that could send some information after the fact on that?
Right. So the best person to answer this question is Dr. Neil Sarkar. I think I'm on a delay, so I can't quite hear you well. But Dr. Neil Sarkar can answer all of your technical questions.
Okay.
Thank you.
I think you still need to turn down your feed and just listen to the phone. That might help with the delay.
Okay.
Yeah. We'll go ahead with a couple more questions if you've done that.
I've done that.
Okay, that'll really help. I have a questions for clarifying because there are a few other people that are going to call in on this bill. And Senator Coyne had a bill that question that does need to be clarified by either yourself or Dr. Sarkar. As I believe from previous years with this type of legislation has been introduced, that one of the clarifications that was very important is that researchers get different data than a provider, than a doctor or a clinician. It's very different data. The data that researchers get, and you can correct me if I'm indicating this wrong, but the data that a researcher gets does not identify the patient, but identifies populations related on what would be important for researchers, like how many people have diabetes and what kind of medication they're getting for it, whether that had any impact on their care, things like that, versus the kind of also restricted information and how it's restricted to comply with HIPAA, that providers, doctors and others, are also restricted based on making sure the database and access to it is still strictly HIPAA compliant. If you could just tell us what part of that you can answer and what part we need to go back to Dr. Sakar in either a follow-up call or written answers from him on that.
Right. So the data for researchers is de-identified?
Correct. Just, we want
and so,
you to confirm that, yes.
But I would ask that Dr. Sarkar comment on it as well.
Yeah. And the second part of my question about that HIPAA is compliant throughout the legislation based on the protocol around what providers are accessing the data.
Completely.
Okay, thank you. I believe there's a question from Senator Bell.
Thank you so much, Mr. Chairman. And I want to add one additional element to this I've noticed from just reviewing this legislation right now in the specific language. And that is the language on line 23 of page 4, section E, which says that state agencies may receive from the Health Information Exchange applicable confidential health information for public health purposes. I understand perhaps some of the reason for that language, and one of my concerns there was that it could actually be used for alternative payment models. But I also am concerned about privacy language. I've been looking through the bill and trying to find some sort of standard boilerplate thing that I would expect to be there that would clarify that information received by state agencies would have to be anonymized, etc. All the standard data protection provisions, which I assume is the intent of the legislation. But I have been unable to find somewhere in the bill, and maybe it is there and I've just missed it, but I want to make sure that we have those protections in place so that information received by state agencies would be, for instance, anonymized at the point of delivery. So the state agency staffers would not be able to see people's individual health records and health information. So I would want to make sure that we put those provisions in place and that the state itself and the state agencies would be bound by all those protections, ideally including HIPAA protections as well.
Right, completely understand. And I would say that Neil can talk more about this from a technical level in terms of what's been done, but I would absolutely agree.
Maybe there's another approach to this that will clarify going forward as we hear more about this from other people who are calling in. But under current care currently, how many Rhode Islanders are enrolled?
I think around 450,000.
Yeah, so it's about half of the people that have medical records are enrolled, and what we're trying to do is get closer to the example I gave of AIDS testing of 99% because it becomes a much more effective and useful both research and data tool for providers. And so I would wondering, with those 400,000 patients that are currently enrolled, has there been an issue based on their enrollment where you've heard or been concerned about data breach, HIPAA violations in access to that care, or the delineation between provider access and research access, or state agency, as Senator Bell brought up, either of those categories being inappropriately used or inadvertently creating a violation?
So the answer is no, and I can. Neil has been communicating with me since he can't call in. That from a HIPAA perspective, the access to data are the same as all other clinical contexts. Yeah. Same security as any other healthcare entity. Researchers only get de-identified data, and all of the information that you requested, that you were looking for in the document, it's in the full bill. This is only asking for changes to particular sections.
Right. So the point I'm getting at is you have 400,000 people enrolled, and it is operated as expected without HIPAA violations, without data breach, and without inappropriate use of data that's specifically for research or a state agency.
Correct.
Okay. I believe Senator Bell has one more question.
Really more just of a minor clarification. The point I brought up about the state agency language, that's new language that's added to the bill. It's not currently in effect, so we wouldn't know what its effect would look like in the existing population because it isn't currently in effect. I just wanted to make sure I clarified that for the record.
Any other questions? I want to thank you for calling in. I believe we'll follow up with Dr. Sakar if there's still, after this testimony, any further interest in getting clarification.
Thank you.
Yep. Okay, I believe we've gotten one of our no answers back, Catherine Hillary. Just let us know if you're speaking on behalf of yourself or another entity and which bill or bills you wish to speak upon.
Sure. Shall I start now?
Go right ahead.
Oh, hi there. Thank you for taking my call. My name is Catherine Hillary. I'm from Newport, calling in to testify in support of S379 on behalf of myself. Thank you so much to our 10 representatives who have signed on to this bill. The sheer number of our elected leaders who have acknowledged that there is a problem with honesty within Rhode Island Medicaid programs administered by managed care organizations should alert the average person like myself to the need for oversight. I think that simply put, private insurance companies are getting paid too much, providers are getting paid too little, and patients are suffering from inadequate care. Evidence of this phenomenon is in the closing of so many hospitals in Rhode Island, which have found themselves in unsustainable financial positions due to having the least profitable patients dumped into their systems by other hospitals. That would be Medicaid patients. My limited personal experience with this was in the first dental office I worked in as a dental hygienist. We rarely received Medicaid patients, but it was very sad when we did because the capitation rates were so low. These patients were poor people who couldn't afford preventive dentistry and would only show up when problems arose. There was no way that all their dental and hygiene needs could be met in a single calendar year with such low capitation rates. I do think that we should go back to the single-payer system that we had for these patients back in 1994. At least then, healthcare providers got reimbursed directly from the state without the greed of insurance companies as middlemen corrupting this process. In the meantime, at the very least, we need oversight audits by the Auditor General. Thank you.
Any questions for Catherine? Thank you for calling in.
Thank you so much.
Oh, Dr. Brown?
Yeah, hi.
Hi there. If you could let us know which bill you're testifying on, and you can go ahead with your testimony.
Okay, thank you so much. So my name is Dr. Joanna Brown. I am testifying in support of Senate Bill 62, and I am speaking both as an individual Rhode Island physician and on behalf of the Rhode Island Health and Privacy Alliance.
Okay, you can go ahead with your testimony.
Okay. So thank you so much, Chairman Miller, Senator Golden, for sponsoring this legislation, and to the members of the committee. I'm a family doctor and an adolescent medicine physician, and I've been practicing in Rhode Island for the past 13 years. And I co-chair the Rhode Island Health and Privacy Alliance, or RIPA for short. Earlier this evening, we heard from Craig O'Connor from Planned Parenthood already speaking quite eloquently about the importance of this bill and talking about the outpouring of young adult voices providing written testimony, explaining why this legislation to protect their privacy is so important. So before I go into the details of the bill, I wanted to talk a little bit about our Rhode Island Health and Policy Alliance, or Rhode Island Health and Privacy Alliance Coalition. It's a broad-based coalition, and the reason it's broad is that a number of people in different situations can be affected by breaches of privacy that occur with insurance communications. So, for instance, we have the Coalition Against Domestic Violence, we have the Rhode Island Medical Society, we have the ACLU, Planned Parenthood, whom we heard from before, the Substance Use Policy Education and Recovery PAC, or Super PAC. We have Open Door Health, which is an LGBTQ clinic. We have the Rhode Island branches of the AAP and ACOG, that's the pediatricians and the gynecologists. We have the Women's Fund and other groups, individuals, and advocates. So it's a great group, and it's growing. To spend a few moments talking about how the bill functions, I really appreciated Senator Golden's great introduction. We have been working on this for several years, and we're quite hopeful that this year we'll get it over the finish line. In this bill, a person on another person's insurance, so that could be a young adult or a spouse or an adolescent who is not the policyholder, they could request that their health communications be sent to an alternative mail or email address or call to a specific phone number. And that's if they don't want the insurance communication to automatically go to the policyholder. These requests can be done through a confidential communication request form that the insurance companies are required to make available, and they can make available on their websites and also have paper copies available that can be distributed. And then the insurers would have 7 days to respond to electronic and phone requests and 14 days to respond to mail requests. And then a very important piece of the bill is that the Department of Health will then have the role of PR, of education of the healthcare providers in terms of what's going on and how they can assist their patients. And then as you, Senator Golden, and Senator Bell were talking about at the beginning, oversight right now is given to OHIC and DOH. So we're going to hear from other people providing testimony tonight about how this privacy issue affects people in a number of situations. I'm going to talk about just two. In one case, for instance, I did want to talk about behavioral health. We are in the middle of a behavioral health epidemic right now, nationally in Rhode Island. COVID is unfortunately pushing a number of people to the breaking point. 1/4 of young adults aged 18 to 24 years said in a recent CDC survey that they had seriously considered suicide in the past month. So that's 1/4 of young adults. We have to make sure they can access the care they need safely and confidentially, and we don't want barriers to be in the way, such as fear of insurance disclosures. Now I want to switch gears and share with you a snippet from a story from Maria Zhu, a Brown student. She got reproductive health care while she was at college, and the EOBs went home to her parents. They criticized her, they yelled at her. It was incredibly upsetting, and from now on, she is going to have to pay out of pocket for such services. She also works for Brown Emergency Services, and she says that when she and others arrive for a student who's in need of medical emergency care, the first question they ask is often, will my parents know about this? She says she's had very sick students refuse transport to the hospital because they were afraid of their parents finding out. So I commend Maria's letter to all of you. It's powerful testimony, as is the testimony of the other young people who have written in. And in conclusion, I urge you to please vote Senate Bill 62 out of committee, and I'm happy to take any questions. Thank you so much.
Thank you, Dr. Brown. Are there any questions from the committee? All right, I don't see any. Thanks so much for calling in. Have a good evening.
Thank you so much.
Great, and I believe next we are going to have Dupe Akinremizi. Hi, is this Dupe Akinremizi?
This is her.
Hi there. If you could let us know which bills you're testifying on and if you're representing any organizations, and then you can go ahead with your testimony.
Thank you. My name is Dupe Akinremizi, and I am representing Thundermist Health Center and Woonsocket Health Equity Zone.
Great, thank you. You can go ahead with your testimony.
Thank you, Chairman Miller and the members of the committee. My name is Dupe Akinremizi, and I am a family planning and sexuality health educator in Woonsocket, working on behalf of the Woonsocket Health Equity Zone and Thundermist Health Center. Billing and insurance claims processes need to ensure the confidentiality of adolescents and young adults covered by their family health insurance plans. With the expansion of the Affordable Care Act, provisions allowing young people to remain on their parents' insurance plans until the age of 26, more explanations of benefit forms are being sent home. Confidentiality can be breached when an insurer needs an EOB form mails an EOB form to the policyholder. Adolescents and young adults often avoid important health care appointments because they worry that their private health information will be released without their consent. Although there are positive benefits of parental involvement in an adolescent's health care, and we always ask youth and young people if they can involve their parents in their health care decisions, situations do exist in which parental notification could place an adolescent at risk of verbal and or physical abuse or conflict. It is important that adolescents get the health care they need and are guaranteed the confidential care they deserve. Delaying care for testing, treatment of a sexually transmitted infection, cancer screenings, mental health support, contraception, pregnancy, and or substance abuse can lead to poor outcomes for youth that can span their lifetime and lead to expensive, avoidable healthcare costs. This legislation not only offers a solution to this problem, but also provides a shield of protection for this vulnerable population. Thundermist Health Center urges passage of Senate Bill 62. Thank you.
Great, thank you for your testimony. Are there any questions from the committee?
No, not at this time.
No. All right, thank you. Have a good evening. Okay. I believe we'll be joined next by Enrique Sanchez. Hi, is this Enrique?
Sí, mi nombre es Enrique, a la orden.
Hello. If you could let us know which bill or bills you are testifying on and if you are representing any organizations, and then you can just go ahead with your testimony.
Claro que sí, muchas gracias. I'm here testifying both in Spanish and English for our bilingual communities and Spanish-speaking communities of Providence, Rhode Island in general. Mi nombre es Enrique Sanchez, represento BLM RI-PAC y PROV DSA. My name is Enrique Sanchez and I represent the BLM RI-PAC and PROV DSA. Estoy aquí dando un testimonio en apoyo del proyecto del Senado número 379. I am here giving a testimony in support of the Senate Bill 379. Este proyecto de ley necesita aprobarse por el Comité del Senado. Ya no podemos dejar que compañías de seguro privadas sigan acumulando millones de dólares durante esta pandemia. This bill needs to pass as soon as possible. We cannot continue to have these private insurance companies accumulate millions of dollars every day, especially during a pandemic. Más del 90% de Medicaid está administrado por compañías que se llaman MCOs, organizaciones de atención administradas. More than 90% of Medicaid is controlled by private companies called MCOs, organizations that are controlled by their private investments. Esos grupos de intereses especiales no se preocupan de los pacientes. Desde julio del año 2018, 2/4 o el 69% de todos los beneficiarios recibieron su ayuda por parte de los MCOs, 53 millones de pacientes en total. These groups, these special interest groups, MCOs, don't care about working people, working class people, and poor people. Since July of 2018, 2/3 or 69% of all the benefits of people received help from MCOs. 53 million people in total. There is a lot of money that could be going back to working class people, but instead keep going for these private insurance companies. But thank you so much. Have a good night.
Gracias, Enrique. Are there any questions from the committee? All right, I don't see any. Have a good evening. Thank you for calling in.
Thank you. Bye-bye.